Welcome to the Joint Paediatric Grand Round. I'm Louise Fleming. I'm one of the consultants at the Royal Brompton and also a clinical senior lecturer at Imperial College. And I'm going to speak to you today about severe asthma and its investigation and use of novel biologics. There we go, sorry. So these are my conflicts of interest. I'm supported by Asthma UK, and you can see my other disclosures there. So the overview of the talk, I'm going to give an overview of the approach at the Royal Brompton for how we manage a child who's referred to us with problematic severe asthma. I'm just going to give a brief overview of that and then go through a case which I hope will illustrate some of those steps, and then finally look at treatment of severe asthma. So if you don't remember anything else from this talk, the kind of key take-home message, so I'll give you that now in case you drop off or not paying attention for the rest. So if asthma is not responding to treatment, it's almost invariably because the treatment's not being taken properly, or it's not asthma. There may be comorbidities or the persistence of other factors driving symptoms, and only rarely is it because of genuine severe asthma. So although I'm going to talk about severe asthma in this talk, actually all those other factors are much more likely, and finding children with genuine severe asthma is the least likely option. So how do we define severe asthma? So this was the ERS ATS guideline definition from a few years ago, which still stands. And it's around kind of looking at the level of treatment and then also the level of control. So it's children requiring treatment with high dose inhaled steroids, and I'll show you the doses. So this is GINA steps 4 or 5. Plus add-on treatments, and for our patients that's almost invariably an add-on LABA, plus other add-ons such as montelukast or theophylline, or have been on maintenance oral steroids for at least half of the previous year. And despite being on those medications, they either are uncontrolled, or as soon as you start to reduce those medications, they become uncontrolled. And the definitions for control are an ACT or an ACQ score below the thresholds for control. So we use ACT, so the asthma control test score of less than 20. Frequent severe exacerbations, and that's defined as 2 or more in the previous year requiring a course of steroids, or at least 1 hospitalization in the previous year, or persistent airflow limitation. And these are the current high definitions of high dose. So this is the most recent GINA table. These are not dose equivalent, so there's no kind of easy way of saying this amount of budesonide is equal to this amount of fluticasone. But these are what have been used in studies as high dose. These are kind of based on the license for these treatments. And you'll notice for children 6 to 11, the doses are actually relatively low. So budesonide, for example, a dose of over 400 per day is considered high dose, and fluticasone greater than 200. And for children of 12 and older, they're categorized with the adults, and higher thresholds are used. At the Brompton, we generally kind of use kind of somewhere in the middle. So for budesonide, we would consider 800 or more as high for either age group, and for fluticasone 500 or more. But there are no kind of real cutoffs. But I think we need to be particularly aware in young children that actually at these kind of doses, they are at risk of adverse effects. And so often you see young children who have been escalated to quite high doses. And so before we can decide that it's severe asthma, we need to confirm the diagnosis of asthma, and also exclude or think about modifiable factors. And those kind of, only once those modifiable factors have been excluded and addressed can we say that a child definitely has severe asthma. And we very much see this as solving the puzzle of difficult asthma. And there are lots of kind of factors that we take into account. So obviously the first one is the diagnosis correct? Are there the presence of exacerbating factors, so kind of allergens in the home, exposure to tobacco smoke? Are there other comorbidities? And we do a lot of work on dysfunctional breathing. which can coexist with asthma or can be a distinct diagnosis. And I'm not going to talk very much about that today, because really that's a talk in its own right, and hopefully there'll be another talk on that. And then the really kind of important ones, is the treatment correct? So have they got the appropriate inhaler for their age? Are they being given, the right balance of treatment? And then really the crucial one is that treatment being taken? And so the way that we kind of go about solving this puzzle is to have a very kind of structured assessment of children. So all the children who are referred to us, who are on those sorts of those sorts of treatment thresholds that I've showed you, and have that level of control. So that's most of the referrals that we get. When they first come up to clinic, we go through an extensive assessment process. So we try as far as possible. Sometimes we need to split this, and it's not possible to do on one day. And clearly now we're not seeing people face to face. A lot of this is being done by telephone, and then we have to decide what we're bringing children, which parts we're going to bring children up to do. But in an ideal world, the children are seen by the consultant, the nurse specialist, who really is key to this process, the physiotherapist for an assessment of their breathing pattern. And we also make an assessment of psychology, and that can be with the involvement of a psychology assistant. All children have spirometry and bronchodilator reversibility. We do an exhaled nitric oxide and sometimes induced sputum. We measure their asthma control using the asthma control test questionnaire, and also quality of life. We also have a psychosocial questionnaire, which is a semi-structured interview, which really helps to kind of distill out some of that important information. And as I say, the nurses are really key to really gaining an understanding of the family. We also do the PaeCH, which is the Pediatric Index of Emotional Distress, and kind of looks at anxiety and depression in the child. We measure urinary cotinine as a measure of environmental tobacco smoke, carry out allergy testing, usually with skin prick tests, but also sometimes specific IgEs, and then carry out other bloods such as a full blood count and total IgE. And usually at some point, but after they're referred to us, we do a synaptin test. We tended to do this a little bit later on, but certainly a synaptin test is important to see if there's any degree of adrenal suppression because of the high doses they've been on. Then all children are issued with an electronic monitoring device to see how much of their treatment they're taking, and I'll talk a little bit more about that. And then we also get information from the local team, the GP, and the school. And then many of these children also have a home visit. And again, the information from the home visit can be really important for gaining a better understanding of the family. We then bring them back usually 2 to 3 months later after a period of monitoring. And at that point, we repeat a lot of the non-invasive measures to see if there has been any change, and also look at how much treatment the child has taken. And the aims of this process are to confirm the diagnosis of asthma, identify modifiable factors, and then plan ongoing appropriate assessments and interventions. So usually within the first 2 appointments, we've got a really good handle on what the issues are for the child and their family. And we kind of published our kind of first 100 cases some time ago now, and now over 500 children have passed through our protocol. And we kind of end up with this very kind of simple schematic. So the children, as they all referred to us, on high dose treatment with poor control, we do our bits, and then we can say, yes, all their poor control is due to modifiable factors. They've got difficult asthma, or they've got ongoing poorly controlled symptoms despite attention to these modifiable factors. They've got severe therapy resistant asthma. And when we first published, it was about 50-50 into these groups. And now we've got much better at doing it. We're finding the balance is much more towards difficult asthma, with around probably 80% of the children referred to us we would classify as difficult asthma. However, we've also increasingly recognised that this is too basic a schematic, and that actually children don't divide very simply into these groups. And so this figure kind of shows kind of the more of a kind of real life picture, that yes, many children will have difficult asthma, but there can be overlap with severe asthma, or they can have asthma plus with comorbidities. But even once we've kind of addressed those basics, even if we know somebody's not taking their treatment, if they're still having severe life-threatening attacks, they've still got severe asthma and we need to do something about it. So we've kind of moved from that very kind of basic schematic to thinking much more broadly about the children that we see. And so this is our kind of overall view of the assessment. So I've gone through the kind of the first multidisciplinary assessment. As I say, the aims of that are confirming the diagnosis, and clearly if it's not asthma, we need to investigate other causes, identify those contributing factors, and then have, put our modifications in place, try and work with children and their families to see why they're not taking treatments, give advice around allergen control, around smoking, and then a lot of time is spent addressing the psychosocial issues. And if control is improved after all of that, great, we're all very happy. However, we have a group who, as I say, have severe asthma, or this group with refractory difficult asthma. We still haven't managed to address those issues, but they are still at risk. And then this group then go on to further investigations, including bronchoscopy, a more detailed immunology screen, kind of more detailed measures of inflammation. And we also do an assessment of steroid responsiveness, whereby we give an injection of triamcinolone and look at their response to it. And then we move on to the targeted treatment plan. And the bronchoscopy studies can yield a lot of very important information. So during that time, we collect lavage fluid, biopsies, and as I say, we also measure a lot of similar measurements to the ones I've illustrated before, and then look at what happens after we've given a dose of intramuscular steroid. And the reason for giving it that way is we absolutely know the child has got it, and so we can see what their steroid response is. And we can look at the structure of the airway. Is there any malacia? Is that why they're having lots of problems? We can look at features of the biopsy and look at airway remodeling, sputum cytology, and also, very importantly, infection. And then when we look at the response to steroid, we look in 3 domains. We look at lung function, inflammation, and control. So that's kind of quite a quick gallop through our whole protocol. And that gives you an overview of all the kind of the workup that we do for individual children. And what I've not, shown you in very much detail, I'd say a lot of the input from the nurses, particularly around the home visit and the work that they do with the family, and also the huge kind of psychosocial element to the children that we see who are referred to us. And we're very lucky that we have a psychologist who's part of the team. And if anyone has been to our meetings or comes to our meetings, you'll know that we spend most of our time talking about the psychosocial aspects. And we get quite excited actually when we have a child with genuine severe asthma, that we can focus on that. So I'm going to go through a case. So this is a 14-year-old girl who was referred to our team. She was an ex-prem. And at the time of referral, she was really presenting a huge amount. So she was actually going to her GP or the emergency department almost every week. She'd had over 10 courses of steroids in the past year. Now remember, the kind of threshold for thinking about severe asthma is 2 or more. So we're way beyond that. She'd had 1 hospital admission, and she was using vast amounts of salbutamol. And this was reflected in a low asthma control test score of 7. And she identified colds, exercise, and pollution as her triggers. At the time of her referral, she was on Symbicort, 200/6, 2 puffs twice a day. She was also taking Montelukast, cetirizine. She had an adrenaline auto-injector. She also had a history of nut allergy, and she was on some vitamin D, and she had a history of eczema as well, but was just using emollients. Her initial workup, she wasn't obese. She had a wet cough when we saw her the first time and a hoarse voice. And she told us she'd always had that hoarse voice. She'd been an ex-prem and there'd been some damage, some vocal cord damage as a result of intubation. And so she had this persistently hoarse voice, which actually made her sound very breathless as well. She was tachypneic when we first saw her, but her oxygen saturations were okay. Her chest was clear. She had a high exhaled nitric oxide, and her lung function was terrible. So this is her spirometry. So you can see her initially a very low FEV1 of only 33%, with scooping of the flow volume loop showing airway obstruction. And when we gave her salbutamol, she improved her FEV1 to 52%. So a huge jump in her lung function after salbutamol. So whenever I see a patient for the first time, I kind of go through a series of questions. So first of all, is this asthma? And surprisingly, a lot of patients who are referred with this kind of this history will come with completely normal lung function and no evidence of airway inflammation. But actually in her case, clearly she has evidence of reversible airway obstruction. It didn't reverse to normal, but there was some degree of reversibility and airway inflammation. So the next thing, well, even if she does have asthma, are all her symptoms due to asthma? So we know we've got this history of vocal cord damage. And also there was some disconnect. She was presenting a lot to the GP or the emergency department, but actually had only been admitted once. So actually, is she feeling very breathless because of dysfunctional breathing rather than always because of asthma? Now, in her case, you have to say if you've got an FEV1 of 33%, you're going to be persistently breathless. But there was just that kind of thought with her. And then why is control so poor? And almost always the answer to this question is control is poor because the treatment's not being taken. And particularly seeing that level of reversibility, if somebody's taken their combination inhaler with a long-acting beta agonist that morning, we wouldn't be expecting to see 50% reversibility. So what would you do with her now? So she's turned up for clinic, she just walked in, she's, this is her normal state. So would you admit her? Would you give her a course of prednisolone and arrange to follow her up fairly soon? Give her triamcinolone because you're not sure she's going to take the prednisolone and then see her in 4 weeks' time. Give her some antibiotics if she's got a wet cough, or actually think she's on 200/6. She's not yet on high dose for her age. Would you increase her ICS dose? So Nicola's going to sort out the voting. So if you all vote now, and just to say there's no right or wrong answer, it's your kind of opinion. So just give you a few more seconds to vote. Okay. So, oh, can you see the results?
Yes, we can.
Okay, great. So, so the majority would admit her, and I think that's very reasonable. Other thoughts were giving her prednisolone. Nobody wanted to give her any antibiotics, and also increasing her ICS dose. And of course, they're not mutually exclusive because we can do more than one. We can admit her and increase. And in fact, in this case, she was actually given a course of prednisolone because she said, "Well, no, I'm no different to how I normally am, and I don't want to stay, and I've got something to go home to." So it was quite a battle, but that's what happened with her. Although I must say, reading this case, I would definitely admit her. Okay. So let's see if we can move on. There we go. So one of the things we need to think about in terms of making that decision as to what treatment we're going to give and whether we need to admit is thinking about a risk assessment. And the two kind of really key things that you're worried about at that point when you're seeing somebody with that degree of lung function and that degree of symptoms is what is their risk of an asthma attack and what is their risk of dying from asthma. And this systematic review from a couple of years ago looked at those risk factors. The ones at the top in red are the most highly associated with risk of a future attack, and the size of the bubble shows the kind of strength of evidence. And so you can see right at the top here, with a greatly increased risk of attacks is a previous attack. So an attack in the last 12 months is the biggest risk factor for another attack. And you can see the evidence for this is very strong. There were a number of trials that were included, and they all showed exactly the same, that a single attack is a risk factor for another attack. And I think I'm showing you this really to highlight the fact that when we see children who have an asthma attack, it's very easy to think, oh, well, that's almost what asthma is. That defines asthma. and it's just, you know, a single attack, but actually that single attack predicts another attack, and it's not a discrete event, it's part of a chronic disease, and that's how we need to view it. And a single asthma attack should be an absolute red flag for thinking, what's gone wrong with this child's management, how can it be improved, and what do I need to do to prevent a future attack. Those other features which come out as increasing the risk are persistent symptoms, poor access to care, and this particularly comes out in US studies, suboptimal ICS, and the ratio is salbutamol, and comorbid A to B and allergy. So they're the, and you know, when you think about the girl that we've got here, she's got all those risk factors. In terms of asthma deaths, we've had no shortage of asthma death reviews in the UK, 5 in the last 20 years, the most recent of which was the National Review of Asthma Deaths in 2017. And again, they show over and over again similar risk factors for why children die: poor adherence, overuse of reliever medication, adverse psychosocial factors, inadequate monitoring, and lack of a personal asthma action plan, and comorbid food allergy. And actually, if you look at data from the UK, our mortality figures are among the worst in Europe. I've shown you here some WHO figures. Ingrid Wolf's data from in children shows exactly the same, the highest mortality in Europe, and the recent Nuffield data replicates that again. We are not doing well in terms of asthma deaths. So with her, I think people who said admit her were completely right, because she ticks all those risk factors, and we need to do something to get her much better. So we subsequently did some other investigations. She had a normal chest X-ray. Her full blood count showed blood eosinophils of 0.8. The rest was normal. Total IgE was elevated at 545. She had positive specific IgEs to house dust mite, cat, dog, and grasses. Her sputum actually grew strep pneumoniae, so she did get a course of antibiotics. Her home visit was small but clean. They didn't have any pets. There was no smoke exposure. Single parent family, and mum had a lot of pressure in terms of work to support the family. Carried out an adherence check, a prescription check, and she had collected 13 salbutamol inhalers in the past year and 2 Symbicort inhalers. So remember, she was on Symbicort 2 puffs twice a day of the 200/6. So my next question is, how long should that Symbicort inhaler last if she was taking it as prescribed? So should it be 6 months, which is, you know, would be 2 per year, which would be what she's collected, 4 months, 2 months, 1 month, or you're not sure, but you think her Symbicort should last longer than her salbutamol, which we can see it has done because she's needed more salbutamol than Symbicort. So I'll just give you a few more seconds to vote, to do your calculations. Okay. So most people thought it should last 2 months. A couple of people thought it should last longer than her salbutamol, that your salbutamol should be the one that you're running out of quickly. And 2 people thought 1 month. Oh, okay. So in fact, if we do the calculation, try and move on. So the 200/6 inhaler has 120 doses per inhaler. She's on 4 puffs a day. So 1 inhaler should last her for 30 days. So you can see she was taking, so she should have had 12 inhalers in a year, and instead she was having 2. She'd only picked up 2. And of the 2 that we picked up, we've no idea how much of that she had actually taken. And what's really worrying is how much salbutamol she had collected. So she collected 13 inhalers. And in fact, your salbutamol inhaler should be the one that you're not using. So that should be the one that's lasting a long time and you're not needing frequent repeat prescriptions. It should last for a much, much longer time than your Symbicort. And why do we worry about people who use so much salbutamol? Well, we know that high daily use, so at least 2 actuations a day, or use on 2 or more days a week in 2 weeks, is associated with an increased risk of attack. And there's lots of reasons for that. So the most likely in her case, it's discordance between her ICS and her SABA. She's using lots and lots of salbutamol to relieve her symptoms, but not using her inhaled steroid to prevent those symptoms. It could just be indicative of poor control. So even if you are taking your inhaled steroid, but your control is still poor for whatever reason, you might need lots of salbutamol to relieve those symptoms. There's also evidence, and Seb Johnson's published a lot of work on this, about actually the harmful effects of salbutamol, and that it can cause, if you overuse it, it can cause an increase in bronchial hyperactivity and actually an inducement of pro-inflammatory pathways. So the very thing that you're taking to prevent, you're making worse, and therefore you're setting up a vicious cycle of actually of salbutamol being less and less effective, causing more problems, and therefore needing to take more to address that. And there are also some children who have polymorphisms in the beta-2 receptor, and again, meaning that the salbutamol is less effective. And in the National Review of Asthma Deaths, they kind of define 12 inhalers a year as being high a risk for asthma death, and that is actually a huge amount. So 12 inhalers a year means that you're taking 6 puffs per day every day. So absolutely industrial doses of salbutamol, and we should be thinking much lower. So children who are collecting 6 inhalers per year should be ringing alarm bells. And this work from Sami Suisa, it's quite old now, but still it stands absolutely true. An increased risk use of SABA is associated with an increased risk of death, and an increased use of inhaled steroids with a decreased use of death. So it's about switching that ratio away from using lots of salbutamol and towards using inhaled steroids. So we gave her a monitoring device, and this was her adherence. It was only 33% when she was being monitored. Remember, most people, when they're monitored, will likely take more treatment. So what do I mean by these monitoring devices? Well, we have smart inhalers which attach to the child's usual inhalers, and we have them for a range of devices. And they record the time and the date of the actuation, and so they can let us know exactly how much was taken and when it was taken. And then from that, we can put children into these categories. So if while they're being monitored, they have good adherence and their control is good, well, that's great. And we've kind of achieved what we need to do. And we need to support them to maintain good adherence and can likely step down their treatment. If they have good adherence, but their control is still poor, then these are the children who need to step up in treatment and we need to move on. For those with poor adherence, we still see a group who actually, despite poor adherence, have pretty good control, and we need to find the right level of treatment for them to maintain that control. And then we have this group, which is the case with our patient, who's got poor adherence but has persistently poor control. And what we don't know is whether actually, if she took her treatment, would she then move into the good adherence improved control group, or the good adherence persistent poor control group that obviously we do very different things with. And so what we did with her was to start her on directly observed therapy at school so that we would know that she was actually getting her treatment. We changed her to the SMART regime because she was using a lot of reliever, that she would use her Symbicort as a reliever inhaler and therefore would be getting more of her steroid as well. So even if she forgot doses, if she was then taking extra doses as a reliever, that would make up for that. And initially she did have some improved control. Her exercise tolerance remained poor. She was still very breathless. When we saw her, she had variable lung function and despite directly observed therapy, required further courses of steroids and had a severe life-threatening episode. So clearly, despite directly observed therapy, she's still doing very badly. We need to move her on to another treatment. And generally, we tend to do that rapidly. We don't wait for children to have lots of courses of steroids. And the other difficult group that we have quite a number of particularly teenagers who, despite the fact we start directly observed therapy, they don't go to school, or don't go to school very often, so we don't know how often they're having their treatment. And again, if they're having attacks, if they're having life-threatening attacks, then we need to do something else. We can't just leave that risk. So hence we need to go on to think about what drugs we would then add on, having escalated inhaled steroids. So this is a very nice kind of schematic showing the pathophysiology of asthma, and in particular the cells and the cytokines that are involved. And we've done a lot of work on this at Imperial, and particularly kind of understanding what types of inflammation are important in children. And what really seems to drive inflammation in asthma, particularly eosinophilic inflammation, T2 cytokines, so IL-4, 5 and 13. And then there's also this group here with non-allergic eosinophilic airway inflammation, who rather than the driver being allergens, it's more caused by pollutants, cigarette smoke and infection. But both pathways lead to increased number of eosinophils. And what you can also see is that the cytokines that are important for eosinophil activation and trafficking, so I'd say those T2 cytokines, also lead to pathways which upregulate inducible nitric oxide and leads to an increase in exhaled nitric oxide. So exhaled nitric oxide is an indirect measure of eosinophilic inflammation. It's not produced directly by eosinophils. And as you can see, there are other pathways which can lead to increases in eosinophils without necessarily inducing FeNO. So I think we just have to be a little bit careful about using exhaled nitric oxide as a very direct measure. It can be a good biomarker for eosinophilic inflammation, but not always. And also importantly, there are other cytokines, particularly IL-33, which can also lead to increases in inflammation via different pathways. But these are the kind of the key ones, so we're going to focus on these. And they have led to a very kind of rich pipeline of medications for asthma, so focusing on these this T2 pathway. So since this paper is only 2 or 3 years old now, the ones in green here are had been licensed, and these are now turning green. So down to Jupilamab are now licensed. And as you can see, they're targeting IgE or 4, 5 and 13. And I'll concentrate on these ones because there hasn't been so much progress with the bottom half. So for children and adolescents, it's just worth highlighting that of the 5 drugs I'm going to talk about, Omelismab is licensed from 6, Lipo is also licensed from 6, Benyrel and Omelismab are only licensed in Europe in adults, although Benralizumab is licensed in the US from 12, and Jupilamab is licensed from 12 but isn't yet NICE approved. And you can see that despite being despite having an indication for adolescents, only Omelismab has carried out studies. There have been studies of Omelismab specifically in that age group. All the others were included in adult studies and there's no subgroup analysis. So we're having to extrapolate adult data. So Omelismab is anti-IgE, binds to the IgE receptor, and also kind of downregulates the receptor as well, limiting mast cell granulation. It's licensed, as I say, from 6 within a range of IgE between 30 and 1500 and is given as injections every 2 to 4 weeks. And this is a kind of recent systematic review looking at reduction in exacerbations, and you can see that overall there's a benefit. And there have been in total 8 double-blind randomized placebo-controlled trials in children from 6 years of age, plus additional real-world data. And most of those studies have shown a reduction in frequency and severity of exacerbations, as well as improvements in quality of life. And the real-world data has showed no new safety signals. So I think Omelismab is the one that we've had for the longest. It's been around for a long time now, over 10 years now, and we've got a lot of experience of using that. But it doesn't work for all children. And just to kind of highlight another potential use for Omelismab, so something that's very reproducible is the September peak. So every September, there is a surge in asthma attacks, and this is replicated all over the Northern Hemisphere, and there's a similar autumn peak in the Southern Hemisphere in January. And so in this study from the US, they gave Omelismab or an inhaled steroid surge only during the the summer before the September peak. And for those with severe asthma, they didn't have an increase in the inhaled steroids because they were already on a high dose. They were just given Omelismab or placebo. And what happened in those in lower treatment groups and those with severe asthma, there was a reduction in exacerbations during September for those either given high dose steroids or Omelismab compared to placebo. And in this group, you see the ones who are given the ICS boost, there was also a reduction, although not as much as with Omelismab. And there's some mechanistic data that suggests that as well as having an impact on allergen exposure and mediating the allergic response, Omelismab also has an interaction with rhinovirus and therefore prevents rhinovirus-induced exacerbations. So this isn't kind of being used clinically, but it just does demonstrate that perhaps using for shorter periods rather than continuously could be useful. So moving on to the next one, so IL-5, as I said, it's a key cytokine in eosinophil function, both for activation and eosinophil trafficking. And the original studies, this was the original study of mepolizumab, which targets IL-5, didn't show any difference between the different doses of mepolizumab and placebo. And so that the kind of whole program for mepolizumab was largely shelved. Until, of course, it was pointed out that if you're going to target eosinophils, then you need to target patients who've got eosinophils, because particularly in adults, not all adult patients have eosinophilic asthma. And when the study was rerun, only recruiting patients with evidence of eosinophils in their sputum, then you see a significant difference between placebo and mepolizumab. And there were two studies, one from Leicester and one from Canada, which were published at the same time. And therefore, the whole kind of mepolizumab program was reignited. And the big dosing study, the DREAM study, and subsequently the Immensa study were carried out, which again showed these differences between placebo and the various doses of mepolizumab. And so this has led really to a huge shift in the approach to all the monoclonals, of actually about recruiting the patients for whom it's likely to work, rather than just saying we're going to include the whole population with asthma. If you're targeting a certain cytokine that targets a certain cell, then you have to have evidence of either that cytokine or that cell for it to be effective. So that was mepolizumab. What about younger children? I said it's licensed from 6. So this is all based on a single study, a non-randomized open label study of 36 children, all of whom were given the active drug. And it was a safety study and also looking at the pharmacodynamics and pharmacokinetics. They found on the PK and PD study that generally exposures were higher than in adults and children had lower clearance. But there was also a reduction in blood eosinophils, which was similar to that seen in adults. The initial study was then extended and 30 children carried on. The other 6 dropped out because there was absolutely no effect, or they had had a worsening of their asthma during the study. And during that time, half the children had at least one asthma attack on treatment. However, they compared it retrospectively to their pre-treatment number of asthma attacks and actually published to say that that was a demonstration of efficacy. Well, I don't think you can say that at all on the basis of this study. It was an open label study, there was no control group, and the number of exacerbations pre-treatment was completely based on parental recall. So I don't think we can say anything about efficacy in this age group. All this study, this very small study, tells us about is about safety. However, it has been licensed by the EMA for use from 6 years of age on the basis of these data. So the other IL-5 drug is reslizumab. Again, the data are very similar to the one I showed you for mepolizumab. Again, with reduction, that's placebo, that's reslizumab, and time to exacerbation was increased in those who were on benralizumab, and also improvements in their quality of life score. The other thing to point out about reslizumab is that it's given by intravenous injection rather than subcutaneous injection. Benyrel is a little bit different in that although it is another anti-IL-5 drug, it actually targets the alpha subunit and therefore will also mediate antibody-dependent cell cytotoxicity of eosinophils and basophils. So it's seen as being potentially more effective than the other IL-5 drugs because they allow IL-5 independent migration of eosinophils into the tissue, whereas Benralizumab doesn't. And that's given as 3 doses every 4 weeks and then 8 weekly, and that's by subcutaneous injection. And there was also one study which looked at giving a dose of Benralizumab to adults with acute asthma who presented in the emergency department. The diamonds show the placebo group and the squares and the triangles, the different Benralizumab doses. And in fact, with the lower Benralizumab dose, there was a significantly increased time to next exacerbation with a single dose of Benralizumab. And then finally, of the MABs, Jupilamab binds to the IL-4 receptor, and that blocks signaling of both IL-4 and IL-13. And it's given by subcutaneous injections every 2 weeks. And again, it's shown a reduction in exacerbations in the studies, but also it's the only one that's really shown a difference in lung function. And Jupilamab has previously been licensed for eczema, so it has good efficacy there. So you've got lots of MABs, 3 of which target IL-5, and which to choose. And I'm sure some people will look at this slide and see 3 very different cars. I just see 3 big black cars that I can't really tell the difference between. And to many people, the MABs are the same. How do you actually choose between them? So there have been a number of studies which have tried to look at responders and who might better respond to each treatment. So this is as I mentioned before, for Omelismab, not all children will respond. So even if you fulfill the criteria, those criteria, so the total IgE level, isn't a predictor of response. It's not a biomarker that predicts response. So in this study, they looked at markers of T2 inflammation, looked at exhaled nitric oxide, blood eosinophils, and serum periostin. And they found that those participants who had high levels of these, and particularly if you had all 3 high levels, you are much more likely to get a significant reduction in exacerbations than those who had low levels of those biomarkers. So suggesting that that might help to better predict those who would benefit from Omelismab. I mentioned before that when we do our bronchoscopies, we give a dose of triamcinolone to look at steroid response, and we look at that in a number of domains, including lung function symptoms and inflammation. And we kind of ask the question as to whether could that response to steroid, could that tell us anything about response to Omelismab? And in fact, in our study, even though exhaled nitric oxide in itself didn't act as a predictor of response, if you looked at those who had a significant fall in their exhaled nitric oxide when they were given a dose of triamcinolone, they were much more likely to have a significant reduction in exacerbations on Omelismab. So again, we kind of use that as a guide to think, well, actually these ones might be more likely to respond to Omelismab. The Benralizumab study also looked at predictors of response and found that prior exacerbations came out top. And again, that's something we find with Omelismab as well. Given that with all the MABs you see a reduction in exacerbations, you're more likely to get an improvement if you're somebody who has an exacerbating phenotype rather than persistent symptoms. And most of them have shown very little benefit with symptoms. And then Dupi also looked at a number of biomarkers and found that blood eosinophils were a marker of response, particularly higher levels, but also elevated exhaled nitric oxide. So maybe we've got a little bit more of a clue as to which one we should choose. And Gina have produced these very nice kind of flow charts to say, you know, if somebody's got evidence of T2 inflammation, think about these things when deciding which one to choose. And the first thing to consider are, you know, things like how often they'll have to come up to the hospital. Is it a 2-weekly or 4-weekly? Is it subcut? Is it intravenous? What drugs are licensed and available? And then going down each of these, looking at the eligibility. So for Omelismab anti-IgE, are they sensitized? Do they have a serum IgE within range? Do they have the right number of exacerbations? The anti-IL-5 drugs, again, it's based on exacerbations, and in this case, blood eosinophils. And Dupi is based on, again, exacerbations, blood eosinophils, and is the only one that elevated exhaled nitric oxide is one of the eligibility criteria. And then factors which predict good response. So for anti-IgE, high exhaled nitric oxide and blood eosinophils, and those with allergy-driven symptoms and childhood onset asthma. So it seems to be more effective in children as well. Anti-IL-5, again, high eosinophils, exacerbating phenotype, nasal polyposis. And interestingly, those with adult onset asthma seem to do better. And then for anti-IL-4, again, high blood eosinophils, high pheno, associated atopic dermatitis and nasal polyps. So going back to our case, if you remember that, which option would you choose for her? So would you choose Omelismab, Mepolizumab, Benralizumab, Reslizumab, or Jupilamab? You can vote now. Okay. Do a couple more seconds. So most of you have plumped for Omelismab, and that's certainly the one that we've got most experience of. One person's gone for Mepo and one Benra, and she did have elevated blood eosinophils. So if we remember for each of those, Omelismab is licensed, so we could use it, and Mepolizumab is also licensed. For the others, only Benra and Resli aren't licensed for her age group, so they're not available to us. Jupilamab is licensed, but is not yet NICE approved, so we would have to use a patient access scheme. So for her, we're really talking about Omelismab and Mepolizumab. Omelismab, I showed you or demonstrated there's been lots of data. Mepo, less so. However, for her, there are some other considerations. So Omelismab was 2 weekly injections and Mepolizumab 4 weekly. And so she actually was very needle phobic. So we put it to her and discussed with her the different treatments and which would be most, which we thought would be effective, and let her make the decision. And in fact, she chose Omelismab, which I was quite surprised by. I thought she'd go for Mepo because of the number of injections. And interestingly, we started her at the time when we were just really starting to use Mepolizumab, and I think we were much more comfortable using Omelismab. Kind of having started a lot more children on Mepolizumab, particularly someone like her, a teenager with kind of a very eosinophilic, she kind of is almost more of that kind of adult eosinophilic group that we see, the kind of non-allergic eosinophilic. And I think I might be now more likely to start her on Mepolizumab. And we've had a teenager recently who we've switched, who we went through the same pathway. We started Omelismab and she hasn't done very well. So currently, she's been on Omelismab for 6 months, very well. No oral steroids or hospital admissions. Her GCSEs came to an end. And we switched her to Relvar, so a once daily treatment, which we thought would help with her adherence as well. And we're in the process of transitioning her to adult care. So in summary, severe asthma represents only a small proportion of children with asthma, and it's really important to carry out a systematic assessment and address and kind of understand those modifiable factors. And it's a dynamic process, and there needs to be continual reassessment. So in this case, even though we knew she had poor adherence and we tried to do something about it, actually she had a life-threatening episode, and therefore we needed to think again. And teamwork and working in partnership with young people and their families is essential. And there is an exciting pipeline of new drugs, aided by a better understanding of the pathobiology of asthma, but it is based on adult data. And I think we need to continue to really very strongly campaign that, we have studies in children that can answer those questions. And in fact, we're about to start a study of a head-to-head of Omelismab and Mepolizumab in children from 6, and the purpose of that study, or the main aim, is to really try and define who are the responders and what are the biomarkers for response. So I'd like to thank all the team at Imperial and the Brompton and all the the various teams who've worked with us over the years, and also our funders. So thank you.
Thanks, Louise. And I've just sent a reminder to everyone that if they have any questions, then obviously they can type them in the box, and we'll be able to read them so that hopefully you can answer them. We haven't seen any so far.
Okay. Does anyone have any questions they want to ask? I think, oh, there's a comment from Saji that you could see my answers. I didn't realise you could. Could you see the next slide? I wasn't sure which view you could see.
I think it also depends how people have their screen set up.
Okay. Okay, so there's a question from Andy. What about biologics in the preschoolers? So I think the preschool group are probably the most difficult to manage, and those of whom we have the poorest understanding. There is a study starting in the US, the PaeCH study, and it's actually a disease modification study using Omelismab. So they're going to randomize children who have got risk factors for developing asthma. So preschoolers who've had episodes of wheeze, who've got a parent with asthma and have atopic sensitization. And they'll be randomized to placebo or Omelismab for 2 years. And the outcome of that study, the primary endpoint, is whether they develop asthma. So that's only just started to recruit. So we'll see whether there is a disease-modifying effect of Omelismab. But as far as I know, there is a kind of a reluctance to use biologics in preschoolers because of potential kind of immune modulating effects. But clearly there are some children who, despite being younger, have a very, very clear kind of asthma phenotype, and we have used Omelismab in children younger than 6. And actually they seem to have done well on it, provided they kind of fulfill all those criteria. Oh, so a question from Saji Alexander. Any effect on calcium or bone? So in terms of steroids, so I'll just answer that one. So in terms of steroids, yes, there is. We don't know, we certainly know that, or there is some data suggests that inhaled steroids reduces bone mineral density, and that's something we're very interested in at the Brompton and monitor. Also, however, there are some conflicting data that if you have better asthma control, you're more likely to be active, and that improves your bone mineral density. So I think it's about getting that balance right between achieving optimal control and giving the right level of treatment. But it's certainly something that we look for. We also measure vitamin D, and there's some evidence that low levels of vitamin D increased steroid resistance. Yes, that is something that is monitored. Oh, so Saji said from biologics. So no, not as far as we know, there's kind of no data on that impact. I would have thought that the better, as I say, the better your asthma control, and if you're better, if you're more active and can reduce the amount of steroid that you're on, that will have a positive impact. But that's, as far as I know, there's no data on that. And Andy's posted a kind of a challenge to everyone. So most data we have is extrapolated from adults. Not really satisfactory. How can we do better? So I think that's something that's a challenge for all of us. And we need to continue to advocate for children. But we need to find ways to address this pragmatically as well. One of the problems is that, particularly for the biologics in children with genuine severe asthma that fulfill these criteria, there's very small numbers. So it's quite difficult to actually set up, a big kind of licensing study and recruit enough children. And therefore, that's why I think kind of the more pragmatic studies are important. So the one that we're doing that's or kind of open label studies looking, as I say, we're looking at Omelismab and Mepolizumab, but it's also really important. I think the regulators need to do better with this, is to saying, yes, we've licensed this drug from 6, we have very limited data, and therefore post-marketing surveillance needs to be really good and mandate that as part of the license. And they seem quite reluctant to do that. You see that much more in CF drugs, where there's really good post-marketing surveillance. And again, I think that would be a way to address that issue. Okay, any more questions? Okay, so in that case, I will wrap up. This presentation will be available in the shared file, and Nicola will send the link round to that. So thank you all for coming this morning and for your participation. And yeah, I look forward to seeing some people in person, hopefully in the not too distant future. Okay, thank you.
Louise, much appreciated on behalf of all of us. And just a reminder to everyone else, we're back next week with Bob Boyle taking us through milk allergy. Right, thanks everyone.
Okay, thank you.
Thanks, Louise.
Okay, thanks, Nicola. I'll see you.
Great.
Okay, cheers. Thank you.
All right, take care. See you later.
Bye-bye.